Here we are at the second part of pharmacological concepts. Now, let me take you back to the last slide of the first part and just briefly review that. The albumin is the most prevalent protein in the plasma, and it is the most important to which the drugs bind. So only unbound or free drug molecules can leave the vascular system. These bound molecules get stuck. They cannot get out and do their work. So this affects distribution. Another thing that affects distribution is the blood-brain barrier. This is a barrier in your body that prevents certain substances from getting into the brain and into the spinal column. Later in the semester, we'll talk about strategies that providers use to get past that blood-brain barrier for treatment purposes. Let's talk about metabolism or biotransformation. This is the biochemical alteration of the drug to an inactive metabolite, a more soluble compound, a more potent active metabolite, or a less active metabolite. This is primarily done through the liver enzyme system. The hepatic microsomal system is two phases. We have phase 1, where oxidation, reduction, or hydrolysis of the drug via the cytochrome P450 system or the enzymes occur. And then phase 2, where conjugation reaction occurs, then that makes the drug less polar and more readily excreted by the kidneys. Less prominent in metabolism are the skeletal muscle, kidneys, lungs, plasma, and the intestinal mucosa. Here you can see a schematic about drug transport and metabolism. The parenteral drug or the oral drug goes into the plasma. It very rapidly will hit the liver, the major site for the metabolism. Then the metabolites, some of those will be protein bound, some of them will be free. Some will go to the storage sites. At times they may be released back to the plasma or to the tissue receptors or the site of action. And then those metabolites will be excreted, with the kidneys being the major site of excretion. So when we're talking about metabolism, there are some things that decrease metabolism. That is cardiovascular dysfunction, renal insufficiency, starvation, obstructive jaundice, being a slow acetylator, and ketoconazole therapy, ketoconazole being a specific drug. What is a slow acetylator? Well, acetylation is the process where there's the addition of acetyl. Now think about that for just a minute. We have a neurotransmitter, acetylcholine, right? So acetylated organic molecules then have the increased ability to cross over through those selectively permeable membranes. So if you have someone whose body does that more slowly, that could be a decrease in their metabolism or their biotransformation of a drug. Subsequently, or conversely, I should say, there are also things that increase metabolism. For example, maybe you have a fast acetylator. There are medications like barbiturates, rifampin, and phentoin, which can increase metabolism. And we'll study more about those drugs, so don't get too hung up on the medications themselves. Just understand that there are medications that will increase metabolism. Let's talk briefly about pharmacotherapeutics. Now, what is the difference between a therapeutic effect and a therapeutic window? Well, the therapeutic effect is the response after a treatment of any kind, the results of which are judged to be useful or favorable. And this is true whether the result was unexpected or completely expected. It can even be an unintended consequence. The therapeutic window, however, is the range of doses that produce a therapeutic response without causing any significant adverse effect in the patient. This is a ratio between a minimum effective concentration, or how much you need to really be effective, and the minimum toxic concentration, or how much could be poisonous. If we look at this mix of drugs, the effects of drugs, and the relationship to the therapeutic window. So we administer the drug, there is an absorption, it reaches a peak effect. Then that drug starts to decrease in its level and it becomes eliminated. You can see the administration, the onset, the duration, the peak level, the distribution, all of these things through this graph. We'll talk about this graph in more detail as we talk about specific medications. These will be important when you start to understand the timing of doses. Remember, one of our rights is the right time. Briefly, let me touch on enzyme induction. This is the presence of a chemical that is metabolized by a particular enzyme system, and that often increases the activity of that enzyme system. So this affects other drugs that might be metabolized by the same enzyme system, which is why you could have an increase or a decreased effect of a particular medication. So again, we need to think about, as nurses, the timing of medications. They're not arbitrary. They are specific for a reason. So we have to think about those within the therapeutic effect and the therapeutic window as we administer medications to our patients. Consider how these factors influence drug effects: the person's weight, their age, their gender, the physiological factors such as the diurnal rhythm, when is their sleep time, when is their wake time, their electrolyte balance or their acid-base balance, as well as their level of hydration. We will look at these considerations as we study classifications of each of the drugs. Also, we'll look at the pathological factors, the disease, hepatic function, renal function, GI function, vascular function, and blood pressure. These all can have an effect on the pharmacokinetics of the drug, as well as the pharmacodynamics. And even more things that we'll study with each classification are the genetics or the pharmacoethnicity that affects a drug, any immunological factors that might affect a drug, and psychological factors that affect in medication administration, such as the placebo effect, health benefits, and medication compliance. There are more, yes. What about environmental factors? The temperature, the light, noise? All of these things affect a patient's medication regimen and the administration, metabolism, as well as the pharmacodynamics. Patients may have a drug tolerance. We'll talk about that. And that's not just for opioids. There can also be accumulation or cumulative effect. We see this a lot with our geriatric patients. Let's talk briefly about elimination. This is the process by which the drugs and their metabolites are removed from the body. Now, we said earlier that the majority of this is through the urine. The drug has been made more water soluble by the liver. We also can have elimination of the metabolites through the fecal route, respiratory, through sweat, and through breast milk. When we look at renal drug excretion, we know that it is the primary process involved in drug excretion. So we have an illustration here that shows the approximate locations where these processes occur. We will go into more depth as we look at individual classifications, particularly when we start to talk about hypertension and high blood pressure. What is the half-life? Well, when we're talking about excretion, we're talking about the half-life of the time it takes for the amount of the drug in the body to decrease by 1/2 of the peak level that it had previously achieved. So when we look at this, we realize that this is constantly moving down. It's decreasing. The half-life is decreasing at a steady state, but it's always half of what it was. So the measure is a rate at which the drug is actually removed. When we think about this, we can say that most drugs are considered effectively removed after about 5 half-lives. So if you've completed Bio A, could you guess why? Take a few minutes, think about it. So if you paused your audio here and you thought about that for a few minutes, you would realize that the major route of drug elimination being through the kidneys receive a 1/5 to 1/4 of the cardiac output. So therefore, about 5 half-lives later, you will have considered effectively eliminating the drug. Now let's talk about some side effects, and let me give you some quick examples. We have drug-to-drug interactions. For example, an antagonistic effect if we have 2 drugs in the same class, aspirin and ibuprofen, or an additive effect, aspirin, which is a non-steroid anti-inflammatory, and acetaminophen, which is an analgesic. We could have drugs interacting because of alternate therapy or drug alternatives. St. John's wort, for example, and Prozac. They work and compete for the same sites, so we can get serotonin syndrome. Drug-food interactions, Lipitor and grapefruit juice. So Lipitor will not be absorbed with the grapefruit juice. And then we have drug laboratory test interactions. For example, cephalosporins alter urine glucose and ketone test. This is to say that they affect the outcome of the laboratory test. They don't affect the plasma levels of the urine glucose, or the plasma levels of the ketone, or the urine glucose actually itself. We also have some inherent pharmacological effects of the drug. This is what we want. We could have an allergic reaction. Allergic reaction we've talked about before is when we have an unexpected reaction. We could have a local irritant effect. We see this often with a topical and with a parenteral administration. An adverse reaction is a little bit different than a side effect. So a side effect is expected. We don't necessarily like it, and the patient may not be able to tolerate it, but it is not unexpected. An adverse reaction is an unintended, unfavorable response to a drug that occurs in doses used in humans. So I would like for you to consider trying to find some examples of these in your reading. Antibiotics that cause interactions with other antibiotics, with other drugs, with other foods. How about warfarin? It's affected by many drugs and foods. Caffeine. Does it affect most drugs? Grapefruit. What drugs are affected by grapefruit juice? Grapefruit juice can increase the drug's effect by 3 times. And then our herbal remedies, teas, and vitamins act as drugs. So they can have drug-drug interactions as well as you can have drug-food interactions. I hope that you've been able to absorb this, and I hope that this is, in addition to your reading, helpful to you. As we go through the remaining of the semester, we're going to touch on these basic concepts over and over again. So I look forward to seeing you soon. In the meantime, if you have questions, please feel free to text me, put them in the Canvas, email me, the discussion forum, or give me a call. Till we meet, take care.